Sure. So at PAINWeek, I had the honor of speaking about the Alternative to Opiates program, which I just spoke about, just highlighting some new therapies we have for treating acute pain in emergency medicine. And what was really nice about speaking at PAINWeek is it's a real collaboration among practitioners, pharmacists, and a variety of specialists. So it was not just emergency medicine, but really the whole house of medicine discussing this important topic and looking at what other practitioners are doing. I also spoke about case scenarios and not letting first impressions fool you. And this was a reminder that some populations of patients we need to pay a little bit closer attention to. We need to really look at red flags, especially patients with developmental delay where a history may be limited and our physical exam may be limited by cooperation, remembering to utilize a full resource workup if necessary. And then of course a big focus on geriatric patients in that discussion. We want to remind practitioners that geriatric patients, like pediatrics, are really a different population in the emergency department. And outpatient, they may not have a fever, they may not have the same pain that young people have. And it's just an overview and a reminder that we have to really make sure we do good histories, do good physicals, and we get to the bottom of that patient's complaint, especially paying attention in the extremes of age. There has not been much pediatric discussion at the meeting, and I think that's because it's a difficult population to treat. I think we've talked with some of the administrators at PAINWeek for including a bit of a pediatric track in future meetings. Additionally, geriatric poses another significant challenge: comorbidities, polypharmacy. There has been some discussion about geriatrics at the meeting, and it was nice to be able to contribute to that discussion. But the pediatric and geriatric patient populations, we need more research and we need more attention about how to treat these groups, because there are definitely special considerations that we don't typically pay as much attention to in the adult population. The biggest takeaway was just the fantastic collaboration to appreciate that pain management is everybody's job, from pharmacy to internal medicine, physiatry, emergency medicine. It's really the whole house of medicine, and it affects everybody from young age to very old. It affects people who have insurance, who do not have insurance. So it's a human problem. And in order to do a good job of treating pain and to collaborate and avoid adverse events, we need to really come together and appreciate what each field is doing and how we can help overlap some of these ideas. So when we go to our specialty meetings, emergency medicine meetings or general surgery meetings, it's very cliquey in that we're really only talking about what we're doing in our own departments, in our own kind of island. But when we open it up to all specialties and practitioners, it really makes the opportunities limitless to break through barriers, to really implement change, and to have that affect everybody from outpatient all the way into the intensive care unit. And that's how we're going to fix some of these problems, opiate epidemic, and we're going to help provide quality pain management. It's really just through collaboration, and I appreciate that aspect of PAINWeek. It's been really an eye-opening experience, and there's been a lot of fantastic feedback. I've made good friends, and I hope to be able to work with different universities and different clinicians and pharmacists to continue to better our practice and to continue to spread the work that I'm doing in other places.